still left with the endocrine part of the pancreas. So what we will do in this session is we'll try to cover up in the initial first few minutes, some of the issues related to the endocrine part of the pancreas, and then we will move forward with today's session, which is mainly on the development of the endocrine gland. So if you look at the pancreas is primarily an exocrine gland. That means it produces its secretions into a duct system, and that duct system opens into the duodenum. So if you look at the histological section, you will find these acini. Can you make out these acini? These acini are darkly stained, containing pancreatic secretions which are going to open into the duct system. So this is the exocrine part of the pancreas. In between these acini, you would find these pale staining clusters of cells which are called islets of Langerhans, and they form about 1 to 2% of the gland. So this is the endocrine part of the gland, which consists of clusters of cells, pale staining clusters of cells in between the acini. So 90%, 99% of the gland is acini, and then in between, then you would find pale staining clusters of cells, which form 1 to 2% of the gland, and they are called islets of Langerhans. These are the endocrine part of the pancreas. Now, these pale staining clusters of cells are going to secrete several hormones, and they also are going to have different types of cells. So the three major types of cells which you find in the islets of Langerhans are alpha cells, beta cells, and delta cells. There are others also, but you at least have these three major types of cells in the islets of Langerhans. The other thing about islets of Langerhans, the most abundant of the islets of Langerhans are present in the tail of the pancreas. So the most concentration of the islets of Langerhans would be seen in the tail of the pancreas. Now the alpha cells are responsible for secreting a hormone which is called glucagon. Beta cells are responsible for secreting insulin, and delta cells are going to secrete somatostatin, which we do not know the function here because it's the same structurally somatostatin which comes from the hypothalamus to the pituitary. But we do not know the function of this hormone here, but we know that the delta cells are the ones which are going to secrete somatostatin. Now on hemotoxin eosin staining, within the islets of Langerhans, you cannot differentiate the alpha cells, the beta cells, the delta cells. You would only see clusters of cells. So you are unable to differentiate alpha, beta, and delta cells on hemotoxin eosin staining. So you need specialized type of staining to identify these type of cells. And the type of stain the specialized type of stain which is used for identifying these cells is called Mallory-Aslan staining. On Mallory-Aslan staining, when you stain the islets of Langerhans, you would find that the alpha cells are going to look red. So alpha cells, this is a Mallory-Aslan staining. Alpha cells are going to, would be red. The beta cells are orangish, as you can see here. So beta cells are orangish, and the delta cells are blue. Yes?
Now what are we staining exactly?
We are staining the islets of Langerhans. So the islets of Langerhans, which are the clusters of cells which form the endocrine part of the pancreas, we said that there are three different types of cells, alpha, beta, and delta. But they cannot be differentiated on hemotoxin eosin staining. So you need to do a specialized stain which is called Mallory-Aslan staining.
I understand, but what exactly is the cell are we staining?
You are basically staining the three different cells which are, based on their cytoplasmic appearance. You would differentiate. If the cytoplasm stains red, then you have, the alpha cell. If it stains orangish red, then it is the beta cell. and then if it is the delta cells, they are going to stain blue. We do not know which organelles or which structures within the cell are being stained by that, but you need to know that Mallory-Aslan stain is used to differentiate between the three types of cells in the islets of Langerhans. There are other cells also, like PP cells and epsilon cells. These are also part of the islets of Langerhans. So if you look at it, the current classification tells you these are the three major cells: beta cells secreting insulin, alpha cells secreting glucagon, delta cells secreting somatostatin. Then the PP cells are the ones which secrete pancreatic polypeptide, D1 cells secrete vasoactive intestinal peptide, and EC cells are the ones which secrete the secretin, motilin, and substance P. So these three are the minor type of cells which are present in the islets of Langerhans. Now this is the cellular mechanism, how the beta cells are going to secrete insulin. So what happens is that when you have high levels of glucose in the blood, the glucose is going to enter into the beta cells through the GLUT2 receptor, and as it is going to get into the beta cells, it is going to be responsible for the formation of ATP. And as ATP is formed, this ATP is going to bind with this ATP-sensitive potassium channel and closes this ATP-sensitive potassium channel, resulting in depolarization of the beta cells, which induces the calcium influx into the beta cells. And as the calcium is going to bind to the insulin-containing vesicles, these vesicles are going to granulate and secrete insulin into the bloodstream. So this is the mechanism of how the insulin is secreted in response to glucose. But beta cells are not only sensitive to high glucose levels, they are also stimulated by sympathetic and parasympathetic innervation. And parasympathetic innervation will result in increased release of insulin, and similarly sympathetic stimulation is going to decrease the insulin secretion. So you need to know that not only beta cells are sensitive to glucose, they are also innervated by sympathetic and parasympathetic nerve supplies. Now before I go to insulinoma, we also need to know that in conditions where there is an autoimmune destruction of beta cells, you have a condition which is called type 1 diabetes. And in type 1 diabetes, because there is no insulin and because of the autoimmune destruction of the beta cells, there is hyperglycemia. And when you have hyperglycemia or high blood sugar level, there is a renal threshold for glucose reabsorption. After that, it is going to go into the urine, and as the glucose is lost into the urine, it is going to take the water with it. So there is going to be osmotic diuresis. So these people would have polyuria, they would have polyphagia, they would feel hungry, so they would try to eat a lot, and they would have extreme amount of thirst. So polydipsia, polyuria, and polyphagia, these are the types of symptoms which you are going to see with type 1 diabetes. In type 2 diabetes, there is the beta cells are still there, but you have resistance to insulin because you need insulin in most of your tissues for glucose to be absorbed. If the insulin, there is resistance to insulin and your tissues cannot utilize glucose, then you have a type, the second type of diabetes, which is called type 2 diabetes. And it usually happens with obese people. So if you have obesity, hypercholesteremia, you can have insulin resistance developing, which can result in type 2 diabetes. So in type 1 diabetes, there is an autoimmune destruction of the beta cells. In type 2 diabetes, there is depression in the insulin secretion, but mainly the issue is the resistance to insulin, and that's why you are unable to utilize glucose. Now we are coming to a tumor of beta cells, which is called the insuloma. It's a rare condition, but it's worth knowing because it is frequently tested in the exam. So it's a high yield type of stuff. It is not very common. It's a rare tumor. But when you have insulinoma, you have something which we call as Whipple's triad, and we will tell you what is a Whipple's triad. But first, you need to understand that when you have hyperglycemia, that means increased blood glucose level in normal people, your insulin level is going to go up. Okay? And when your glucose level is going to go down, your insulin level should also go down. What happens here is that because there is a tumor of the beta cells, you would have raised insulin level, and you would have hypoglycemia. And because of hypoglycemia, you would have symptoms of hypoglycemia like nervousness, sweating, progress to lethargy, confusion, and coma. So these are hypoglycemic symptoms. You would have decreased blood glucose level, and the third thing is high insulin level, and that is called the Whipple's triad. So if you have low blood glucose, less than 50 milligrams per deciliter, and still very high insulin level, this means that you probably have insuloma. But you need to differentiate insuloma from an exogenous use of insulin secreting drugs. For example, people use these secretagogues, which induce insulin secretion endogenously, or they inject themselves with insulin. So if there is an exogenous insulin, you need to differentiate: is it the exogenous insulin coming in, or it is an endogenous tumor of the beta cell, which is basically causing this problem. So to differentiate that, you would look at the C peptide, because you know that the insulin is secreted as proinsulin and then it is cleaved. So if it is endogenous, then you would have high level of C peptide, high level of insulin, and low glucose. If it is an exogenous insulin which somebody is injecting, then there would be no real C peptide, and that would differentiate between an insulinoma or exogenous injection of insulin. Yes.
I'm taking something such as exogenous growth hormone. Shouldn't that also increase insulin?
Yes.
You have high C peptide as well.
Yes. If you are using a drug, but if you are injecting an insulin, synthetic insulin, then it would not have a high level of C peptide.
And would exogenous growth hormone cause similar levels of insulin as?
Yes. Yeah, but then this would be similar if you are injecting growth hormone. Okay, so this is what I wanted to talk about. To talk about the development of the pituitary, thyroid, parathyroid glands. Adrenals we have talked about, so we are not going to touch adrenals here. Pituitary, as you know, consists of two embryologically and functionally distinct divisions. We know that the adenohypophysis is more of a glandular tissue which arises from the Rathke's pouch, while the neurohypophysis is basically a neural tissue which is coming from the diverticulum, from the third ventricle. So the development of the pituitary gland begins in the 4th week of intrauterine life with inductive signals which starts to come from the diencephalon. And these inductive signals, the molecular inductive signals which are coming from the floor of the diencephalon, they are going to induce the epithelium around the stomodium to develop the Rathke's pouch. And by the 8th week of life, the primitive adenohypophysis separates from the oral cavity. So this Rathke's pouch separates from the oral cavity, and the primitive pituitary cells undergo rapid proliferation with differentiation into specialized hormone cells like somatotropes, electrotropes, and others. Adenohypophysis consists of, as we know, pars distalis, pars intermedia, and pars jugularlis. Neurohypophysis originates from the neuroectodermal emargination of the tissue from the diencephalic floor, which grows towards the stomodeal roof, an extension of the third ventricle. It persists in the neuroectodermal diverticulum of the forebrain, and neurohypophysis is divided into median eminence, infundibulum, and pars posterior. You can see it here. This is the Rathke's pouch, and you can see the infundibulum here, which is coming down from the floor of the diencephalon. This figure is showing you around 11th week of intrauterine life, where you have the globular formation of anterior and posterior pituitary. Regulation of pituitary embryogenesis involves a cascade of genes expressed during the 4th week of life in the diencephalon, initiating the formation of Rathke's pouch, and later a combined expression of multiple genes throughout the stomodeal epithelium required for morphogenesis of the pouch and proliferation and differentiation of hormone-specific cells. In the newborn, around birth time, you would find the pars anterior and pars posterior both uniformly right on the T1 weighted image of the MRI. The reason is that around the birth or prenatally, you have excessive hormonal secretion from the pituitary, and as a result, when you take an MRI, there is a bright image of the pituitary just after birth. This signal intensity and size of the pituitary is going to become similar to older children and apparent by 2 months of the age. So by the 2 months of age, as the hormonal secretion is going to go down, the brightness of the pituitary gland, which you would see just after birth, and the size is going to reduce and become uniformly normal as for the older children. So right after birth, you can see the MRI would show you a bright image of the pituitary gland, because around birth there is excessive secretion of the glandular secretions from the pituitary. Okay. Now we are going to talk about a condition which is called transfoidal encephalocele. Do you know what is an encephalocele? Have you heard about encephalocele? You have heard about spina bifida. Have you heard, all of you, there is, if your vertebral arch doesn't close, then part of your, spinal cord or the covering of the spinal cord can bulge out. So if there is the covering of the brain, which is called the meninges, if they bulge out, then it is called meningocele. If you have the brain tissue coming out, bulging out from somewhere, then it is called encephalocele. So when you hear the word encephalo, that means the brain tissue bulging out from unfused bones. It can be an encephalocele there. If the skull bones do not fuse, then you can have an encephalocele, a brain tissue bulging out from the skull. Or it could be only the meninges bulging out, then it is called the meningocele. Okay? Now, when we call transphenoidal encephalocele, it means the sphenoid bone which is there between the nasopharynx and the cranial cavity. If it doesn't fuse, then the brain is going to bulge down into the nasopharynx. Okay? So part of the hypothalamus, part of the optic chiasma, pituitary gland, with the meninges is going to bulge into the nasopharynx because there is no fusion of these sphenoidal bones. So this is called transphenoidal encephalocele. But if you have an encephalocele here, you can see it. But if you have something in the nasopharynx, when the child is born, you cannot see it. So you call it an occult encephalocele, characterized by a bone defect in ethmoid or sphenoidal bone, and usually diagnosed later because you cannot see it. So what would happen is that the child will be born, he is unable to suck the milk. Why? Because when he is sucking the milk, the nose is blocked because there is a bulging of the brain into the nasopharynx, so he cannot breathe from the nose, he cannot suck the milk. So there is obstruction of the nasopharynx, which will result in failure to thrive, failure to grow, and as a result, you would take the child to the physician, and when they are going to look at the nasopharynx, they will find there is a bulging of the brain tissue within the nasopharynx. So hypothalamus, pituitary gland, third ventricle, optic nerves, chiasma may be located in the amphelocele sac, and typically clinical presentation is nasal obstruction, difficulty in feeding, and failure to thrive. Yes?
All of these structures, they are located exactly in line with the sella turcica. So
Yes.
is it where the sphenoid bone fuses?
Yes, it's the sphenoid bone which forms the sella turcica. So if it doesn't fuse, then there is a communication between the cranial cavity and the nasopharynx.
So when the bone fuses, so it's like the sella turcica is in two halves and then you fuse it there.
Yes. There are two sphenoid bones which are going to join and form the sphenoid bone in the center. So you can see it here. This is the encephalocele sac. You can see the CSF is getting into it. It's getting into the nasopharynx. So this is the encephalocele, and the blue arrow is showing you the pituitary here. The bright shadow here, this is the pituitary, and the whole of the brain, the hypothalamus with the CSF is bulging into the nasopharynx. Congenital abnormalities of development of the hypothalamo-pituitary axis. So what you can have is a hypoplastic pituitary gland, and this is a congenital disorder which may affect the adenohypophysis, neurohypophysis, or the stalk. So it can affect the anterior pituitary, the posterior pituitary, or the stalk. Patients with pituitary hypoplasia can survive with hormonal replacement. So if you have hypoplasia, you still can survive with hormonal replacement. But if you have aplasia of the gland, that means totally non-development of the gland, then you cannot survive. It's not, it's not suitable for life, because you need ACTH, you need TSH, which are very vital for life. So if there is aplasia, then that is incompatible with life. You can survive with hypoplasia with hormonal replacement, but aplasia is incompatible with life. Pituitary dwarfism due to deficiency of growth hormone is a common clinical presentation of hypoplastic pituitary gland. This is showing you hypoplastic pituitary gland. You can see the pituitary tissue is a very small tissue here in both these diagrams. This is a coronal section, this is a cellular section, and you can see a very small pituitary gland here. You can also have ectopic neurohypophysis. That means ectopic posterior pituitary. So normally the posterior pituitary is coming from the floor of the third ventricle, and then infundibulum, and then the axons are going down into the posterior pituitary. So the ectopic neurohypophysis is characterized by a bright spot along the median eminence of hypothalamus or along the stalk. So it is not going all the way down. So it can be in the median eminence or it can be in the stalk. Adenohypophysis and sala may be small with the abnormal, or ectopic neurohypophysis, and it is also frequently associated with growth hormone deficiency, although this is an ectopic neurohypophysis, but it can also result in abnormalities usually associated with growth hormone deficiency and pituitary dwarfism. Association can be with the midline CNS abnormalities like holoprosencephaly, where you would have only one cerebral cortex, and there could be problems with the olfactory bulbs, there could be problems with optic nerve. So there could be problems with midline structures with the abnormality in terms of the ectopic neurohypophysis.
Would the growth hormone decrease because of the obstruction?
No, it is not because of that, but it is associated with it. It doesn't necessarily be a cause of it, it's just associations. like prosencephaly is an association with ectopic neurohypothesis. Okay, next we are coming to talk about the thyroids and the parathyroids and the thymus gland. For understanding that, you need to know that there is something called the pharyngeal arches. These arches develop in the neck region of the embryo around the 5th week of development. So around the 5th week of development, you have these arches developing in the neck region of the embryo. And because they look like gills of the fish, they were initially called branchial arches. So if you hear the term branchial arches, it is the same as pharyngeal arches. But because they look like gills, because if you have bulging at the neck, it would look like the gills of the fish. That's why the initial anatomists, when they looked at it, they called them branchial arches, which are, they resemble the gills of the fish. Now, there were initially the 6 pharyngeal arches will develop in the neck region, and then they would be reduced to 4. So you would have ultimately 4 pharyngeal arches, 1, 2, 3, and 4 in the neck. But when you see the adult neck, you find that this neck is quite smooth. You cannot see any bulge here. Do you see any bulge here? No, it's a smooth thing in your neck. So what happened, we'll show you in a minute. So in each arch, the core is the mesoderm. On the outer side there is ectoderm. On the inner side there is endoderm. So on each arch in the neck, the core is mesoderm, outer side ectoderm, inner side endoderm. So on your skin there is ectoderm. On the inner aspect where you have pharynx, larynx, it's all endoderm, and the core is mesoderm. Now on the outer side, because of each bulge, there is 1, 2, 3, and 4 bulges. You can see in between these bulges, these are clefts. Can you make out these clefts? 1, 2, 3, 4 clefts. And on the inner side, the endoderm, there are pouches. 1, 2, 3, and 4. Okay? So on the outer side, you have clefts, the pharyngeal clefts. On the inner side, you have pouches. Now, as we further develop, the second pharyngeal arch is going to overgrow the third and the fourth arch. So as these arches are going to grow, the second is going to overgrow the third and the fourth. So your second, third, and fourth grooves are going to be finished. The only groove which is going to be left is the first, which is going to give rise to the external auditory meatus. So the first cleft which you see here is going to be left. It is going to give rise to the external auditory meatus, because the second arch is going to overgrow the third and the fourth. The second, third, and fourth clefts are going to obliterate. But the pouches are still going to be there. So the pouches are going to give rise to different structures. The first pouch which you see here, which is an endodermal pouch, is going to grow towards the first cleft. So this is going to be the auditory tube, which is going to go from the nose, going to give rise to the middle ear cavity, and is going to give rise to the mastoid antrum. So the first pouch is going to give rise to the tubotympanic recess, which is going to give rise to the auditory tube, the middle ear cavity, and the mastoid antrum. So, and it is going to join here to the first cleft, which is going to give rise to the external ear. The second pouch here is going to give rise to the tonsils. So the palatine tonsils are going to come out from the second pouch. The third pouch, which you see here, is going to be divided into a superior and inferior part. The superior part is going to give rise to the inferior parathyroid gland, and the inferior part of the third pouch is going to give rise to the thymus. And as the thymus is going to descend into the thorax, it is going to bring down the parathyroid, the inferior parathyroid, down with it. The fourth pouch is going to give rise to the superior parathyroid. although it is lower. But because thymus is going to descend, it is going to bring the inferior parathyroid, which comes from the third pouch, down, while the superior parathyroid is going to come from the fourth pouch. And the lower part of the fourth pouch is going to give rise to ultimatobranchial body, which is going to give rise to the parafollicular cells. And these parafollicular cells are going to release the calcitonin. They are also called C cells. They will get incorporated into the thyroid. So we can see it here. The first pouch is going to give rise to the tubotympanic recess, which gives the auditory tube and the tympanic cavity and the mastoid antrum. The second pouch is the palatine tonsil. The third pouch is going to give rise to the thymus and the inferior parathyroid. The fourth pouch is going to give rise to the superior parathyroid, and the lower part of it is going to give rise to the ultimobranchial body, which gives rise to the parafollicular cells or the C cells of the thyroid gland. Now we can see it here. This is the first pouch, which is giving rise to the tubotympanic recess, and this is going to give rise to the middle ear cavity. And this is the first cleft, which is giving rise to the external auditory meatus. The second pouch is giving rise to the palatine tonsil. The third pouch is giving two things: the thymus gland, which is going to descend, and with it, it is going to bring the inferior parathyroid down with it. That's why inferior parathyroid is sometimes called parathyroid 3, and superior parathyroid is called parathyroid 4. So you can see the fourth pouch is giving the superior parathyroid, and it is giving the ultimobranchial body, which is going to give rise to the parafollicular cells or the C cells of the thyroid gland. Then we come to the thyroid gland. We have talked about the superior parathyroid, inferior parathyroid, thymus gland development. Now we are coming to the development of the thyroid. So the thyroid is also endodermal in origin. It is the first endocrine gland to develop. It is the first endocrine gland to develop. It begins at 24th day after fertilization at the junction of the tuberculum impar and cupula. So tuberculum impar and cupula are the parts of the tongue. So if you, in the adult part, if you look at it, the anterior 2/3 of the tongue is tubercular impar, and posterior 1/3 of the tongue is the cupula. The junction of the interior 2/3 and posterior 1/3 is from where the thyroid gland is going to start developing through a diverticulum, and this diverticulum is going to descend down from the tongue in front of the hyoid bone, in front of the thyroid cartilage. So it gives a thyroid primordium or diverticulum, which descends in front of the hyoid bone and laryngeal cartilages, remains connected by a tube to the tongue. At first, this is a hollow tube, then it will become a solid tube, and then it is going to divide into two lobes, right and left. And by 7th week of intrauterine life, it will assume the definitive shape and size and reach the final site. And then by the same 7th week, the thyroglossal duct, which is connecting the thyro means the thyroid gland, and glossal means tongue. So the thyroglossal duct, which is connecting the thyroid gland with the tongue, is going to disappear. And as it is going to disappear, there would still be a proximal opening at the junction of anterior 2/3 and posterior 1/3 of the tongue, which is called foramen cecum. In 50%, there would be a pyramidal lobe present, and this pyramidal lobe may be attached to the hyoid bone by a fibrous or smooth muscle, which is called levator thyroideal glandulae. In terms of histogenesis of the thyroid gland, initially there are solid mass of cells surrounded by a basement membrane and the vascular mesenchyme. The mesenchyme is going to invade the solid mass of cells, giving rise to the cords. And as these cords, during the 10th week of development, these cords of cells are going to break down to form clusters of cells. And then by the 11th week, within the clusters of cells, there would be colloid secretion, which gives rise to a follicular formation. So there is a single layer of cell which is covering a colloidal material inside the cavity of the follicle. and thereafter the iodine concentration and synthesis of hormones will begin. So it is around third month of intrauterine life when the thyroid hormones are developing. C cells will come from the ultimobranchial body, which are coming from the lower part of the fourth pouch or the fifth pouch. You can see it here. This is the thyroglossal duct, which is giving rise to the thyroid gland. So this is the area which is called the foramen cecum. In the adult life, this is the area which is the foramen cecum at the junction of anterior 2/3 with the posterior 1/3 of the tongue. And thyroglossal duct is going to go down all the way down, giving rise to the thyroid gland. Now, if this thyroglossal duct, which is the one which is going to give rise to the thyroid gland, if there are remnants of it, then you would have cyst present along the descent of the thyroid gland, and that cyst is called thyroglossal duct cyst. So it can be present along anywhere from the course of the descent of the thyroid gland. Normally the duct atrophies and disappear, but it can include the thyroglossal cyst can be at the base of the tongue, close to the inferior to the hyoid bone, close to the thyroid cartilage, observed by the age of 5 years. Mostly it is asymptomatic. Thyroglossal cyst swelling is painless, progressively enlarging, movable mass. So you would find this cyst anywhere from the tongue to the thyroid gland. This is basically a remnant of the thyroglossal duct. It's a painless swelling in the midline. Usually you would be able to observe it around the age of 5 years. If there is an infection of this cyst, then this cyst will open outside into the skin, giving rise to a thyroglossal duct sinus. So when you hear the sinus, it means there is an infection of the cyst, which leads to opening of the cyst into the exterior, giving rise to thyroglossal duct sinus. These are the locations of the thyroglossal cyst. It can be present near the tongue, the tongue just above the hyoid bone, below the hyoid bone, above the thyroid cartilage. So these are the locations where you can find the thyroglossal cyst. Again, this is just showing you the different places where you can find the thyroglossal cyst, and you can see a sinus here. This cyst is opening outside, giving rise to a thyroglossal duct sinus. You can also have a congenital hypothyroidism. So hypothyroidism can be congenital. Usually what you find in adult life is hypothyroidism, but you can also have a congenital hypothyroidism, which is a primary cause of because of derangement in the development of the thyroid gland, that you can have a congenital hypothyroidism. You can have ectopic or aberrant thyroid tissue. So, because of the development, you can have abnormal or ectopic thyroid tissue. It could be just below the tongue, or it could be anywhere during the course of the descent of the thyroid gland, that you can find the ectopic thyroid tissue. You need to differentiate between an ectopic thyroid tissue and the thyroglossal cyst, because if you remove this thinking that this is a thyroglossal cyst and that is an ectopic thyroid tissue, and that might be the only thyroid tissue there, you might lead to hypothyroidism, because there would be no hormones then. So you need to differentiate between a thyroglossal cyst and an aberrant or abnormal or ectopic thyroid tissue. There might be accessory thyroid gland tissue, may appear in the thymus superior to the thyroid gland, in the neck, lateral to the thyroid cartilage. Size is sufficient to maintain normal thyroid function of the thyroid gland. Originates from the remnants of the thyroglossal duct. There might be agenesis of the thyroid gland, absence of the thyroid gland. One or both lobes is a rare anomaly. In case of the thyroid hemiagenesis, that means there is half side of the thyroid is not there. Usually the left lobe is commonly absent. the right lobe still is usually there. Thank you very much. We'll stop here.